Welcome to Texas Briefing, where we wrangle and untangle the policy challenges shaping life in the Lone Star State. We're coming to you from Rice University's Baker Institute for Public Policy in Houston, Texas. I'm Elena Marks, a senior fellow in health policy at the Institute. This episode continues our earlier series on reproductive health. Today, we're looking at how insurance coverage, public programs, people who aren't covered by anything, impacts the ability of Texas women to use their preferred contraceptive method and the barriers they face when they access care. We're joined by Gracia Sierra, a non-resident scholar at the Baker Institute and a data scientist at Resound Research for Reproductive Health, a Texas-based research collaborative focused on emerging issues in reproductive health and policy. So let's get to it. Let's start with the basics. When we talk about a preferred contraceptive method, what does that mean in everyday language?
Let me talk to you first about what current contraceptive method is before going into what preferred contraceptive method is. So when we talk about someone's current contraceptive method, we're referring to the method they're using right now to prevent a pregnancy, if they're using any method at all. And so when we're talking about a method, these methods can include any form of birth control, all the way from condoms to the pill, patch, ring, to long-acting methods like intrauterine devices, which we call IUDs, to implants, all the way to permanent methods like vasectomy and tubal ligation. It can also be the case that somebody is not currently using a method, in which case that current method is none. Now, when we talk about preferred contraceptive method, it's a little bit different. Preferred contraceptive method refers to the method a person would like to use if they could choose any method. It's the one that best fits their needs, their values, and life circumstances. So think about having all the range of methods available to you. The method you would choose, given any option, that's your preferred contraceptive method. And so, if somebody right now is using the pill and they would like to use the pill if any method were available, then we say that they're currently using their preferred method and hence they have a met contraceptive preference. On the other hand, if we have somebody who's currently using a condom, but they would prefer to be using the pill if given the choice, then they're not currently using their preferred method and they are experiencing an unmet contraceptive preference. Now, unmet contraceptive preference can also occur among people who are not using a contraceptive method but would want to be using a given method.
So, Gracia, why does it matter whether people are able to use their preferred method rather than any method that's available?
People should use the method that works best for them, right? A method that they are happy with. And if they're happy with using that method, they're more likely to continue using it. You are more likely to use a given method correctly and consistently if it's the method you want to be using. And that matters because if you're using the method in the right way and consistently, you're less likely to experience an unwanted pregnancy. And as we know, right now in Texas, it's very difficult for Texans to end an unwanted pregnancy, which makes preventing these unwanted pregnancies even more critical than ever. And so when thinking about why one method might work for some people and not work for others and how they make choices about which is their best method, it's important to note that contraceptive methods really vary along several dimensions. And so, methods vary based on cost, effectiveness at preventing pregnancy, whether or not they prevent sexually transmitted infections, frequency of use, among others. And so at the same time, people have different priorities. They have different preferences, different needs, and different lives. And so for some people, cost might be the most important thing, and so they might want a contraceptive method that is the cheapest option for them. For others, it's all about convenience of the method. So not having to go to a clinic multiple times is what matters the most. For others, it's more about effectiveness of the method or privacy. And so, for somebody in an intimate partner situation, for example, being able to use this discrete method can be especially important. On the other hand, we also know about side effects of contraceptive methods. A method that works perfectly for one person might actually cause side effects or complications for another. And so the bottom line here is that there's not a one size fits all approach, which makes it really important for people to get the method that is going to work the best for them and which is going to make them continue using that method in the correct way over time.
Got it. So it's complicated. And thank you for explaining that to us and the various dimensions that people consider when they make a choice about what kind of contraception is best for them. So, what are the consequences? What happens medically, emotionally, socially, financially if somebody can't get their preferred method?
There are consequences both at the state level, or I would say at the system level, and for the individual as well, right? And so at the state level, it really creates unnecessary strain on the healthcare system. It ties up an already limited number of appointments and uses resources that could go to helping others. From a policy standpoint, that's inefficient. Repeated visits to the healthcare provider wastes time and resources for both patients and healthcare providers. And so, on the patient side, the person seeking their preferred method, this person might have to take several buses to reach a clinic. They may need to make a trip multiple times and have to take time off work for every visit, in addition to having to pay for it, right? It's also especially important to recognize right now that in Texas, it's very hard right now to end an unwanted pregnancy. And so, if somebody really knows that they don't want to be pregnant, making sure that they can access and continue using their preferred contraceptive method is simply good policy in general, right? Because people are more likely to use contraception correctly and consistently if it's the method that they want to be using, their preferred method, because it's the one that works best for them.
That makes total sense. And when they can't get that, they are overusing the system to try to get what they want. And it's not good for them and it's not good for the system. And we ought to have policies that avoid that and policies that would allow people to get their first choice when they first appear at their provider. Let's move along to some of the data that you've discovered that looks at who has more access to their preferred contraception and who doesn't. So you just published a brief through the Baker Institute, and it looks at women who have private health insurance, women who have coverage through public programs. It could be Medicaid or Healthy Texas Women or some local programs that provide free contraception to women. And then you also looked at people who are not covered by any program. And so, can you walk us through what you learned about those three types of patients and how that relates to whether or not they're getting their preferences met in terms of contraceptive choice?
So, in our study, we're able to use data on Texas women for 2014, 2019, and 2023 to look at unmet contraceptive preference in the state. And so for 2023, we find that more than half of women in Texas have an unmet contraceptive preference, meaning that they're not using the method that they would like to be using. And what's even more interesting is that this unmet contraceptive preference rate has remained high for the past decade since 2014. So we know that in Texas, half of women are not able to get their preferred contraceptive method. However, there is variability based on the type of coverage that they have, right? So as you were mentioning, Elena, we looked at differences across three groups: people who are not covered by any program, people who get coverage through public programs such as Medicaid or Healthy Texas Women, and people who are in private insured programs. And so what we learned is that in 2023, at least, people who have no coverage or who rely on public programs for contraception are more likely to have an unmet contraceptive preference. So they are more likely to not be using their preferred contraceptive method compared to people who are in private insurance. And this gap is actually consistent over time. In 2014 and in 2019, we also saw that people who don't have any coverage or who rely on public health programs are much more likely to say that they are not using their preferred contraceptive method. And so that highlights the role that type of coverage actually has on whether people can get what they need. Now, we're talking right now about unmet contraceptive preference for people who don't have coverage or who rely on public programs, but it's important to also think about what are they using at the moment and what they would want to be using if they could choose any method. And so among people who have an unmet contraceptive preference and who are either relying on public programs or who don't have coverage, they're currently using methods that are less effective. So think about condoms or withdrawals, or they are not using any method at the moment. Ideally, if they were given the option to choose from any contraceptive method and they could choose whatever they wanted, they would want to use more effective methods. So about a third of people who don't have any coverage or rely on public programs would want to be using a permanent method such as tubal ligation, while about 15% would want to be using short-acting hormonal contraceptives such as the pill. It's also worth noting that if we look at people who rely on public health programs, we also have that about a third of people who are not using their preferred method in that category would want to be using long-acting reversible contraceptives such as an IUD or an implant.
So, what are the reasons then, or the most common reasons overall, that Texans aren't getting their preferred contraceptions, particularly for the women in public programs or who are paying on their own?
Yeah, there's a wide variety of reasons as to why people are not able to use their preferred method. And there's also variability in these reasons across the type of coverage that people have. And so, just to give you a little bit of context, in our study, we're able to look at different types of barriers that people have or that have encountered when trying to access sexual and reproductive health care services. And so some of the barriers that we looked at was it a problem to figure out how to pay for the services, finding a provider or clinic that offered services, finding a place that took their insurance, transportation, arranging for childcare, among others. And so, in general, we found that when looking at people who don't have coverage or who rely on public health programs, financial and logistical barriers are the main reasons or the main barriers that people encounter when accessing care. And so, being unable to pay for services was the leading barrier for these two groups. But it was not that important for people who were privately insured. Also, if we looked at people who rely on public health programs, it's important to note that 40% of this group cited having a difficulty finding a provider or clinic that accepted their insurance as a barrier to care. In addition to those financial barriers, logistical challenges such as transportation, taking time off work or school, and arranging for childcare were also common barriers that were encountered by both people who lack coverage and people who relied on public programs. On the other hand, when we looked at the barriers that were encountered by people who use private insurance, they were most likely to report encountering barriers that have to do more with provider comfort and scheduling, more so than with affordability or access. And so our study focused on people ages 18 to 49. So we did not include minors. However, it is important to mention, I think, that minors, in addition to facing all the barriers that I just mentioned, face an additional layer, right? So, for example, we have this parental consent laws that limit access to confidential, affordable services for minors. And also, it's important to note that minors might have more limited knowledge regarding how to navigate the healthcare system undergoing.
This is really interesting. So the public programs, whether it's Medicaid or Healthy Texas Women, they in theory cover all methods of contraception. So if you are covered by one of those programs, in theory, you should be able to get whatever you want. And yet, your research has shown that people who are covered under those programs are not as likely to get what they want as people who have private insurance. So, was there any activity at the state legislature in this most recent session that could improve access to preferred contraception? Those are the programs that the state controls. And if the legislature is aware that while on paper it says women should have their choice of whatever method they want, and they learn that in reality that's not happening, was there any activity to address that gap?
There are two key changes that are worth discussing. So, first, the legislature approved a shorter, simpler application form for the Healthy Texas Women program, right? So, as you mentioned, this is a public health program that really helps low income women access contraceptive care. And so, by making the application easier to complete, more people who qualify may be able to access services, right? And so, when more individuals have access to affordable health care through programs like this, it can really make them easier to get their preferred contraceptive method because it actually reduces some of the barriers that can prevent them from using their preferred method. Second, this year, the budget for the state family planning programs was also increased by $14 million. And so, if there were no other changes in the policy and insurance environment, this increase should, at the very least, help sustain current levels of service or even increase the number of clients that they're able to serve. And so, although our analysis of barriers to care shows that unmet contraceptive preference is more complex than just insurance status or cost, public funding can really help connect people who would be uninsured to reproductive health services.
So we made a little progress potentially, and I assume that you and your colleagues will continue to follow this and see whether these changes actually did improve access to preferred methods. What about changes at the federal level? For example, the major budget bill that passed this summer, the One Big Beautiful Bill Act. Have there been changes that may impact the ability of Texas women to get their preferred method of contraception based on what the federal government has done?
Yes. So I would say that at the federal level, there are three changes that are worth mentioning. So, some of the big changes, such as cutting funding to Medicaid or the termination of Planned Parenthood, may not impact Texas as much since Texas never expanded Medicaid and the state already has some of the lowest income eligibility limits in the nation, leading to even fewer people qualifying. However, the new requirements that increase the cost burden for some visits and add administrative hurdles, like requiring individuals to renew their eligibility every 6 months, may lead to more insurance churn, making care less affordable, and it can also create confusion that prevents people from getting appointments they need to access and maintain their preferred contraceptive method. On top of that, we all know that there's a current shutdown in the government, and the debate revolves around the Affordable Care Act subsidies and whether they should be extended or not. And so, if the subsidies are not extended, it is likely that more people will become uninsured in Texas because many people who rely on these subsidies to make coverage affordable will no longer be able to pay for their insurance and hence will lose coverage. And so, our data showed that people without insurance face more barriers to accessing sexual and reproductive health care and are also less likely to access their preferred methods. So, people who rely on these subsidies to be able to afford coverage will become uninsured and be less likely to access their preferred method. This will also put more pressure on the family planning safety net as more people seek low cost or free family programs, such as getting care through the Healthy Texas Women program, for example. And these programs are already facing limited resources problems. And so having more people try to access them would put pressure on them as well.
Very interesting. So, based on your findings and our current federal and state legislative situations, how do you think we can improve the rates of preferred contraceptive use among Texans?
There are several strategies that could help improve rates of preferred contraception. And there are probably three key strategies. The first one would be reducing the number of uninsured Texans. And the question is, how can we achieve this? So we could simplify applications, reduce paperwork, shorten processing times, and also ensure that marketplace plans are affordable. Expanding Medicaid eligibility would also allow more people to qualify for coverage. And we could also strengthen access to marketplace plans through guidance or assistance from navigators or community organizations to make these plans easier to use. So that would be like increasing insurance rates in Texas. How do we reduce the number of uninsured? The second one has to do more with expanding access to providers who accept public insurance, right? So sometimes we have people that qualify for Medicaid, they go through the process, but then they struggle with finding a provider who actually accepts their insurance, right? So what can be done? Well, we can improve the provider network for people using public insurance in Texas, making it easier for them to be able to find a provider who actually takes their insurance. And so, one way to do this can be by including Planned Parenthood in the Medicaid network. We had robust evidence that shows that Planned Parenthood affiliates are willing to help people overcome structural barriers. They also accept Medicaid plans that other providers don't accept, and they can also serve a lot of patients when allowed to. The third one has to do more with simplifying appointment scheduling and provider information, right? And so, with that, something that can be done is to do targeted outreach and provider awareness efforts to make it easier for Texan women to find care. And this could include improving online and mobile tools to help people find what clinics are close to them, which providers accept their insurance, check the hours of care that are available, and also learn about the different contraceptive methods that are offered. And so distributing this information through community-based organizations could further improve access for women in Texas.
Those are great ideas. With the current political landscape in Texas, some of these solutions you suggested, all of which sound great, really seem unlikely. What do you think we might see as policy solutions in the near future in Texas?
Alina, like you mentioned, some of the solutions are just like, what we would want to see, but might not happen, such as Medicaid expansion. But there are more realistic policies or solutions that we might actually be able to see. And so one of those would be in the absence of Medicaid expansion, Texas can increase program funding for our state's women's health programs, such as Healthy Texas Women, so they can serve more people and offer the full range of contraceptive methods. And in doing so, this would help more Texans access their preferred contraceptive method. Related to more funding to public health programs, this can also increase. A second realistic solution would be having more hours that work for low income people, right? And so with more funds, clinics could offer extended hours. And so by that, I mean like including evenings, weekends, and walk-in appointments so that this providers can actually accommodate Texans who have limited flexibility with their work, school, or caregiving schedules. The third one would be related to enhancing provider participation in publicly funded programs. And so Texas could increase the reimbursement rates and simplify administrative requirements to encourage more providers to participate in these publicly funded programs. And by doing that, like the providers would be able to serve more patients, expand method availability, and ensure people get the method that they want. The last thing that could be done would be improving information and outreach. And so making information about coverage options and availability of providers more accessible can help people find these providers and get access to their preferred method more easily. And so, as I mentioned before, this can involve campaigns that raise awareness among providers, improving online tools so people can see where they can go, what clinics are close to them, what services they offer, and what insurance they accept. And also sharing this information, like I mentioned previously, through community-based organizations to reach those people who do not use digital tools.
So there is still room for improvement in Texas, even in our current political environment. That's something to be hopeful for. You can read the full policy brief by Gracia and her colleagues at the link in the show notes. Texas Briefing is brought to you by Rice University's Baker Institute for Public Policy, which provides meaningful, nonpartisan policy analysis on most critical challenges facing the U.S., Texas, and the world. This episode was produced by Karina Zamel. You can check out our other podcasts and keep up with our latest research and events at bakerinstitute.org. Thanks for joining us.